It is a privilege to be with you all here today. I will be giving a presentation today called Behind the Smile, the Real Face of Mental Health. And I have been a nurse now for a little over 19 and a half years, and primarily my background has been always in mental health. And one of the things that we have been seeing just probably in the past 4 to 5 to 6 years, there is a brand new spotlight right now on mental health, now more than ever before. I think if there is maybe just one silver lining from the COVID pandemic, is that again, there is a brand new spotlight on mental health, which is a wonderful thing. Um, Again, just working with the school of nursing, working with the health system, and just having many networking and communications with other nurses and directors and managers and educators throughout the country. Mental health is a top priority, which is a wonderful thing. So this presentation today on Behind the Smile, the real face of mental health, goes into more in the area of true assessment. When I work with the nursing students from KU, we talk about assessment quite a bit. And with assessment, um, in the non-mental health world, in the acute care, medical, surgical, ICU world, we have data. We have chest X-rays and MRIs and EKGs and labs, and we have numbers and data and things of that nature. In mental health, it is much, much more subjective, which makes assessment even that much more difficult. So today's presentation is really more about, again, looking behind the smile, really trying to find the best ways possible to fully understand how people are doing, how people are feeling, and whether or not someone needs assistance. Trying to determine whether or not someone may be having self-harm thoughts or suicidal thoughts. So it's a key part of today's presentation, and let's go ahead and begin. So, I will always say that nothing ever really fully becomes real until it really becomes personal. And I think whenever we talk about mental health or any kind of mental health topic, inevitably, we will always bring up the word stigma or misinformation. And I think we've come a long way. And I think we've come a long way in improving this over the past 4 to 5 years. But nevertheless, there's still a lot of stigma. There's still a lot of major misinformation related to mental health. And this is no more truer than with suicide. And I think for many years, and this is still kind of the case, and in some areas right now, where many people still think, well, suicide, that just affects, you know, certain small groups of people over there. I've actually seen people make that gesture before and use that verbiage before when talking about suicide. Well, it only affects certain people and they're over there and this is not a mainstream issue. That could not be farther from the truth. And one of the last stats that we saw just last year is that 47% of Americans have some association with suicide. That's almost half of all Americans. And I am a part of that 47%. And I think there are those moments in your life that you'll never forget. And this took place back in the summer of 1997. Seems like a very, very long time ago. Um, my uncle died by suicide. And I remember that day vividly. I was at home. This is the summer before my junior year in high school. And my dad came home from work early one day, which was very unusual and not quite sure what was happening. I could tell something was wrong. And he sat my mother and I down and proceeded to tell us that his brother and my uncle had just died by suicide. And I think there are those moments in your life where you hear something or you see something or it's just so shocking. It's just so unbelievable. Your jaw drops. It just, it made absolutely no sense. My uncle and I were very, very close. He was a good friend of mine. I had just seen him a couple months prior around Memorial Day. He was really into sports, and he was also an ICU nurse. He was an Army veteran. He was married. He was married. He had a 3-year-old daughter, and just the one of the biggest personalities you can imagine. So it was just shocking. It was just truly shocking when I heard that information. And one thing that always stood out to me about that day, I remember that day we drove down to Wichita to be with the rest of the family. And that was easily the single saddest day of my entire life. And, on that day, I remember, being over at my grandmother's house and the whole family was there. And I had never seen my parents cry before. I had never seen my grandparents cry before, or my uncles or my cousins. And it's a term we use a lot in mental health. It's called the ripple effect. And I really think it should be called the tsunami effect because basically it's a term used to describe how someone's death by suicide can affect so many people. And I remember that day, and this is well before I knew I wanted to be a nurse or work in mental health. I remember thinking to myself, I'm like, you know what? If ever there is a moment or a day in my future where I can do something to help stop this, or if there's something I could ever do someday to help prevent somebody from dying by suicide, I hope I can make a difference because I would not wish this experience on anybody. One of the things that was talked about that day, and it was talked about for many years to come, was, quote unquote, why we didn't see the warning signs. As I said earlier, my uncle was somebody who was this massive, big personality, full of life and laughter and joy, and he was an incredible caretaker, and he would always look out for people. He was a nurse. He just had this big, huge, wonderful heart. And I think that kind of goes more into the theme of today's presentation on Behind the Smile, because, on the surface level, he really didn't have any warning signs. But again, as we learn more and more and more about signs and symptoms of people being suicidal, we can learn to identify those warning signs much earlier. As I mentioned, this obviously affected everybody. It was a life-changing moment for so many. His daughter, she was only 3 years old at the time, and now, 20 plus years later, she is a very, very well-respected therapist who does some amazing work working with veterans with PTSD, and it is her entire life's mission to help prevent suicide. Um, his mother, my grandmother, who just passed away last year, she was 95 years old, lived an amazing, wonderful, outstanding life, and accomplished so many things. And one thing that she did after his death, she wanted something positive to come from it in some way, shape, or form. So she actually started her own counseling group. This counseling group was right out of her own living room, and it was a counseling group for mothers who had lost children to suicide. And she had that counseling group out of her own home for over 15 years. And at any given time, she had almost a 9-month waiting list of mothers who were wanting to be a part of this group. And she said, even right before she passed away, she said it was the single most important thing she ever did in her entire life. This obviously affected my life, and whenever I present on mental health or present on suicide prevention or Behind the Smile, my uncle is somebody who I always think about. If there is just one single term or one single takeaway from today's presentation, please let it be this. It is the phrase or the term embracing the awkward. And I even underlined it here. It is, I think, in my mind, one of the true, kind of rallying cries of mental health going into 2024. It's called embracing the awkward. And as I how I explain this is that mental health is hard. Mental health is difficult. Mental health is not easy. Mental health is not easy to talk about. And talking about suicide and self harm, that is also very difficult to talk about. It's very awkward. I've been a mental health nurse now for 19 and a half years. It's no less awkward for me, whether it be in my professional life or my personal life. As a culture, as a society, we have got to get to a point where we say, I don't care how awkward it is. If I have a strong concern about someone's safety, um, I'm going to provide intervention. I'm going to start a conversation. I'm going to ask a question. We're going to review some of the basics of QPR, which stands for Question, Persuade, Refer, a little bit later on in the presentation. But embracing the awkward is about, again, you have a concern about someone's safety, whether it be self-harm thoughts or suicidal thoughts. We've got to get to a point where we say, you know what, I don't care how awkward or strange or even how personal this may be. I'm going to start a conversation. I'm going to ask a question, and I'm going to do my best to make sure that this person is safe, and so I might be able to possibly save a life as well. So embracing the awkward, a key theme for mental health going into 2024. So, kind of going back in time, I started out as a nurse back in 2004. I graduated from the KU School of Nursing, and I was all 22 years old when I first started working as a nurse. And this whole kind of component of behind the smile really was a huge part of my learning curve. I will never forget my very first admission, and I remember vividly reading the intake on this patient. The intake document was probably 15 pages long. And this patient had every single conceivable, imaginable mental health complication. Self-harm behaviors, suicide history, multiple suicide attempts, cutting, burning, scratching, PTSD, borderline personality disorder, all of the above. And so I had kind of an image of who this patient might be or what this patient may look like before they arrived. And when the patient arrived on the unit, I truly did not think this was the patient. She looked like somebody who was ready to interview for a Fortune 500 CEO position. She had probably $1,000 pantsuit on. And again, I truly did not think that this was the patient. And it was the patient, though. And again, what I read on that intake document did not match what I saw and who I spoke with. And throughout our admission process, she had a lot of self-awareness. And she said, Tanner, she said, you're seeing the best of me right now. You're seeing the best of me. And she said, mark my word, in the next 2 to 3 days, you're going to see a lot of my mental health complications really, really, really come out, from my borderline traits to severe depression, anxiety, panic attacks, thoughts of suicide, thoughts of self-harm. She said, at some point, you will see these come out. And I remember giving this report to her psychiatrist. And I could tell that, he knew how perplexed I was with this first admission. He said, Tanner, he said, this is one of the number one, excuse me. He said, this is one of the number one things to keep in mind in mental health. It's one of the key themes of mental health. And his quote was, the bigger the front, the bigger the back. Being sometimes the more a person presents themselves in a certain way, the opposite, how they're really feeling and how they're really doing, is sometimes the complete opposite. So he said, always be aware of that. If someone is overly presenting themselves in a very bright, superficial, happy, overly enthusiastic way, sometimes how they're really feeling about themselves, even with suicidal thoughts and self-harm thoughts, sometimes, how they're really feeling is the opposite of how they present themselves. And as I said earlier, it's again goes into the whole component of why assessment in mental health is very, very difficult. And I call it the subjective factor. That again, in the medical, surgical, ICU, ER world, We had EKGs and chest x-rays and MRIs, and mental health is more subjective, which makes mental health assessment more difficult. And I will always say that my most nervous moment as a mental health nurse when I used to work on the floor was on a patient's discharge day. Because on their discharge day, they're going home. And most of our patients on my old unit, a big part of their admission diagnosis was having self-harm thoughts and having suicidal thoughts. So under no circumstances would we ever want to discharge a patient who was still feeling suicidal. And, we would always use our suicide assessment scale, 0 being nothing, 10 being the highest form imaginable. Are you currently having suicidal thoughts? And the good news is, I think 99% of our patients were always very honest with us. They would always tell us exactly how they were feeling on their discharge day. However, there were some patients over the years where we still had major concerns. And even our psychiatrist said that, they may be telling you everything you want to hear. However, if those mental health hairs, quote unquote, start to kind of rise in the back of your neck, if something doesn't seem right, if something doesn't feel right, trust your instinct, trust your gut, and discontinue the discharge and let us know. And they said you'll never regret doing that. Because again, it's about, in the mental health assessment world, it's about doing what we can to sometimes look behind that smile and really fully understanding how someone may be feeling. One of my favorite quotes regarding behind the smile, and this is a quote: "Helping someone take off the mask can sometimes be the difference between life and death." And again, this is a major theme of behind the smile is, again, assessing, listening, asking the questions, having a true dialogue and a true conversation with people, and really doing what we can to fully identify how someone may be truly feeling. I'll give an example here. And this is just one example of many. I wish I had 5 hours to present on this. This is just one example. I call it the danger of the word fine. That is a major red flag word, especially in the mental health profession. I think just in general, as human beings every day, we use the word fine every single day to some extent. And usually when we say the word fine, we're not fine. Things are not going okay. It could be, hey, how was your day at school today? Oh, I was fine. How are you feeling at work today? Oh, I'm fine. Even how people say the word, that should tell you a lot. And again, just as one small example, especially in the mental health world, when someone says they're fine, that's just maybe one cue, one red flag, one red light flash that should tell us, okay, we need to dig a little bit deeper here to have a better understanding of how this person may be feeling. So, why people put on the masks? And one of my favorite nursing instructors I had when I got my doctorate, she always said, there's always a cause. There's always a reason. There's always a reason why we do things. There's always a reason why we think things. There's always a cause for our behavior. And a term that we use a lot in mental health, this is not a DSM-5 diagnosis, but it's a term we use a lot. And it's really at the heart of behind the smile. It's called smiling depression. And kind of my definition of this is, it is a term used to describe someone living with depression on the inside while appearing perfectly happy or content on the outside. Smiling depression is without a doubt maybe the single biggest barrier we have right now in mental health, not only in the inpatient world of mental health, but just in our daily lives, where if we see people who are on the outside looking in, they're doing great, they're smiling, they're laughing, they're telling jokes, they're the life of the party, they're the caretakers, we have reason to believe that things are going well for them. But again, sometimes the opposite is how they're really feeling. So at the heart of this, why people work hard to hide their true feelings and emotions. So why do we do this? And again, I think this is something in some way, shape, or form, we probably do this every single day. and with just some small examples where, here's how we're really feeling emotionally or psychologically, but we portray ourselves sometimes the opposite in many different ways. So why is it? Why do we put on the mask? Why do we sometimes have such a hard time really showing people how we're really feeling? Here are the reasons why. And there was research to back this up. Fear of judgment. If we're having a mental health concern, it could be depression or anxiety or self-harm thoughts or suicidal thoughts, we have a fear of judgment. That if people find out some way, shape, or form, we're going to get judged, we're going to look down upon. And that's just one more reason why we are doing everything we can to change mental health stigma. And again, I think we've come a long way with this, but I always give the example that, if somebody were to find out that you were seeing a physical therapist for a physical problem, would that bother you? Would you feel reluctant in someone knowing you were seeing a physical therapist? Probably most people wouldn't mind. Okay, I'm seeing a physical therapist. Who cares? I have a bad knee or a bad hip. I'm seeing a physical therapist. On the other hand, if we were to switch it up, if someone were to find out you were seeing a mental health therapist, I think people would care about that. I think you would find some people who would want to make sure that other people would not know about that. Again, things have progressed for the best on this. People are being more and more and more open now than ever before about seeking out mental health therapy and treatment, but still, a lot of people have a fear of judgment. Fear of being a burden to others. I know many people, I can think of 2 people right now in my own personal life who, they didn't want their families to find out. Their mothers, their fathers, their husbands, their wives, or their kids or their grandkids, they did not want them to find out they had a mental health complication because they didn't want to feel as if they were being a burden or a potential future burden. Just embarrassment. I have this in all caps. Again, people have a concern about this. They don't want, they have a concern like, well, if people find out that I'm taking an antidepressant or I'm seeing a therapist or I have a history of suicidal thoughts, people fear embarrassment. Sometimes denial, this is a huge factor for people because this goes more along the lines, as an example, with addictions. A good friend of mine, he was an alcoholic for the better part of 20 years. And for the first time ever, just last year, he is now seeking out professional help and therapy and treatment. And it's turned his entire life around in the best possible way. But he said, for the better part of 20 years, he was in complete denial over his addiction. And it took him hitting absolute bottom before he finally realized he needed some help and assistance. Fear of backlash. There are way too many examples of people who have been in the workplace environment over the past 10 to 15 years, and they have a strong fear that if their boss, if their director finds out that they have depression or a history of suicidal thoughts or a history of mental health complications, they have a fear that they may be fired or terminated or left out of the workplace environment. And sadly, there are some real examples of that happening over the years. Perfectionism, and this is a big one. And I often have a challenge sometimes with nursing students over the years with this because, I always give the example that, we all want to have high expectations. We want to do great things. We want to have high goals and high expectations and do amazing things. However, we're not going to be perfect. I've had at least 4 or 5 conversations with nursing students in the past 2 to 3 years who were crying because they literally didn't get a 100% on their pathophysiology exam. So again, my counsel to them was, it's wonderful you have sky high expectations, but you also have to be realistic. You're not going to be perfect. And I think sometimes as healthcare providers, as healthcare professionals, we want to have that image of just being, on top of things and being in control of things and always having our best foot being put forth. Sometimes it's just not the reality. Sometimes we do have bad days. Sometimes we're not perfect. Sometimes we do make mistakes. So that's a reality for many of us. One of my favorite quotes from one of my favorite nurse managers: realness is hard. We need to find a way to make it easy. And I think this goes more on the line again of behind the smile and just changing that culture where, as healthcare providers, as nurses, doctors, pick your healthcare profession, we have to learn how to be real and be authentic with who we are and how we're feeling and our challenges. And this nurse manager said, I think it's true, that one of the greatest signs of professionalism is when a healthcare professional can walk up to their director, knock on their door, sit in their office and say, I'm having some major problems right now and I need some help. That's a high form of professionalism when people can be that real, when people can ask for help and ask for assistance. So that's really about a culture change, which we're trying to do right now. So I'm a big fan of case studies. I love case studies. I love real life examples. And um, it was hard to use this case study because Robin Williams was one of my all-time favorite people. I love movies. I'm one of the biggest movie fans you'll ever meet. I love and adore movies. Robin Williams was one of my favorite actors and one of my favorite comedians. And so to kind of give you maybe a little more of a point on how amazingly brilliant and funny Robin Williams was, I call this my Mrs. Doubtfire story. This is kind of dating myself a little bit. I came out, I think I was probably 13 or 14 years old when this movie came out, and early mid 90s, I think. And my grandparents, we went to Applebee's, had lunch, and went to go see the movie. And my grandfather was a great guy, but he didn't have much of a sense of humor. He was kind of a stoic, more old fashioned, just not a big laugher, not a big sense of humor type of guy. When we saw the movie, for those of you who have seen it, the last half hour of that movie, my grandfather was laughing so hard. There was a nurse in the theater who actually went in and checked on him because she thought he might be having a heart attack. I mean, that's how hard my grandpa was laughing. So I'm like, wow, any comedian or actor that can make my grandfather laugh that hard, he must have some amazing talent. And Robin Williams was an amazing talent. And he died by suicide back in the summer of 2014. And I remember when he died, just kind of the world outcry was, what on earth happened? People just couldn't believe it. People had no idea that he was having mental health concerns or mental health problems or depression. Even one of his best friends, Billy Crystal, who was practically a brother to him, even said he knew that Robin had some addiction issues, years ago, but he said he had no idea that he was suffering from depression and was suicidal. He said he had no idea. So again, this is kind of the ultimate example behind the smile because Robin Williams he said it was his life's mission to make people laugh and to make people feel good and to bring light and joy into people's hearts and their minds. If you look at some of the quotes here on this slide, I'm not going to read them all, but just some of them. He was the funniest man in the world. He was the ultimate caretaker. He was very productive. He was very protective of his friends, and dare I say, even more protective of the people he barely knew. He always put others first. His thoughts and feelings always came second, if they ever came up at all. And of course, the last quote here, and these are all quotes from people who knew him, people who worked with him. None of us knew the pain he had. It was impossible for us to know. You literally could never ask him how he was doing. He was always busy making everyone laugh and feel loved and special. So I think if you look at a lot of those quotes there, a lot of those quotes remind me a lot of healthcare professionals. Because I think as healthcare professionals, we are really, really good at taking care of other people. That's why we're in healthcare. We want to help other people. We want to save lives. We want to make people laugh and bring people joy and comfort and aid. So we're really good at that. However, sometimes we are not so good in taking care of ourselves and asking for help and assistance when we need it. I mentioned earlier about the example of the ripple effect. Again, how when someone dies by suicide, how that death affects so many people, and then you find out just how amazingly important that person was, and just the amazing difference just one life can make. How all of our lives can make such an amazing difference. I read an amazing tribute that Steven Spielberg gave after Robin Williams died. And Steven Spielberg and Robin Williams, they made a movie called Hook together. It was a Peter Pan movie, came out back in the early 90s. They became almost best friends after making that movie. About 3 years later, as Spielberg kind of wrote out in his memoir, Spielberg made Schindler's List in 1994. And Spielberg said that making Schindler's List was the single hardest thing he ever did. And it was a 74-day production. And he said that for 74 straight days or 74 straight nights, Robin Williams called him on the phone every single night and did a half-hour comedy routine for him over the phone just to make him laugh. And Spielberg said that every morning he would wake up and his stomach would hurt because of how hard he laughed the night before. And he said that bottom line, Schindler's List would not have become the movie it did without Robin Williams. And I had never heard that story before, but it was just, again, just kind of one more example for me on, again, just the impact that just one person's life can have. So going into, again, assessment, and I call this looking past the smile, the clues that are sometimes too obvious. And I give the example that, mental health assessment is hard. We have to listen and pay attention and look behind the scenes and look between the cracks and really identify potential warning signs that someone may be possibly suicidal or having other mental health concerns. However, sometimes those warning signs are very obvious. Sometimes they're so obvious, we sometimes look past them. I heard someone use a quote that sometimes, someone was hiding in plain sight. Sometimes, signs and symptoms of suicide or self-harm, sometimes they're so obvious, we sometimes don't even recognize them. And you can see some of the examples here for people, again, signs and symptoms. If they have a previous suicide attempt, acquiring guns or stockpiling pills, if they have a co-mental health diagnosis like major depressive disorder or PTSD, a sudden, extreme interest in religion or disinterest in religion, drug or alcohol abuse, unexplained anger, aggression, irritability, all the above. The two I want to focus in on here are the ones in yellow, and that's putting personal affairs in order and also giving away prized possessions. If there's another major takeaway I want you all to have from today, is that, again, guys, human psychology is very complicated, and suicidology is very, very complicated. It's very unusual as it relates to how our brains process information and how we act. And what will happen, and this is a very unusual thing to try to explain, so I'm going to do my best with this, is that sometimes I've heard many former patients talk about this, that when someone makes a decision, either consciously or subconsciously, to die by suicide, when they have an actual active plan, they will sometimes look happy. They will come across as being very happy and joyful and hyperverbal and hyper energetic and hyper task oriented, and they're just kind of bouncing off the walls, and they're the life of the party, and they're just full of energy. So when you see someone acting that way, you think, again, well, looks like they're doing pretty well. They're happy, they're laughing, they're doing all these things. However, again, the opposite is the reality. So you might ask, if someone has an active plan for suicide, how come they look happy and full of energy? And I've heard so many former patients talk about this, is that when someone makes a decision to die by suicide, they often feel relieved, knowing that, to quote one former patient, they said they knew very soon that their pain would be over. So therefore, they felt relieved, they felt happy, and that's why they presented themselves in this way. So again, it's something we were always very concerned about in the inpatient mental health world. I know there was one patient, she was 2 days away from her discharge, again, hyperverbal and hyper task oriented. And we saw her in one day shift make 24 different phone calls to people she had known throughout her entire life. And she was wanting to tie up loose ends. Needless to say, we did not discharge her because, again, that was a red flag for us that something was wrong. And also giving away prized possessions. This took place a couple of years ago. My mother, one of her really good friends, her husband died from cancer. And over the next couple of days after he died, my mother noticed that her friend was selling everything she had on Facebook. She sold her dog, she sold her piano, her car. My mom's like, something is not right here. So she went over to her friend's house and spoke with her, and she had an active plan to die by suicide. So I'm very, very thankful my mother was able to identify a very obvious situation that something was terribly wrong. Other factors, I'm looking past the smile, the clues that are sometimes too obvious. I give the example that, every single day, we're in self-preservation mode. We are doing everything we can every single day to make sure that we're keeping ourselves safe, our loved ones, our husbands, our wives, our partners, our children, our grandchildren. We want to make sure we're keeping everyone safe and keeping people happy. However, sometimes, and I call these life meteorites, sometimes something out of nowhere can just happen that turns our lives completely upside down in a very bad way, in a very negative way. And these are, they're called precipitating factors. I call them life meteorites, just something that we had no control over that causes our lives to turn upside down in a very, very negative way. It's so important to know that it just takes one precipitating factor or one life meteorite that could push somebody to potentially becoming suicidal. Even people who have had no mental health history or history of depression or suicidal thoughts, it just takes one of these, which you can read here in the slide, from being fired or being laid off, having to move, the loss of a relationship, the death of a spouse or a child, a terminal illness diagnosis, the loss of financial security, the loss of a cherished therapist or best friend, a fear of becoming burden to others. These are all, again, massive precipitating factors that can completely turn someone's life upside down in a negative way. So again, if we have friends and family, people in our personal lives or professional lives, if one of these things happen to somebody, we should be aware of that and be vigilant with that. Again, all it takes is one of these that could potentially push somebody to possibly becoming suicidal or having self-harm thoughts. The difference between life and death, asking the question. This is called question, persuade, refer. And I've been teaching our standard QPR suicide education and prevention course now for over 2 years with the KU Health System. We offer this course every other Friday from 9 to 10. If any of you would like to take the standard QPR course, feel free to email me at tfunk@kumc.edu. I'll get you signed up. And it's an amazing course. I've had a chance to teach this course not only in the health system, but also to high schools, colleges. And just last month, I had a chance to present this presentation to a construction company conference. It was a convention. There were over 500 people there, all construction workers. I gave the presentation. We had a Q&A session afterwards. And then afterwards, I had one gentleman come up to me with tears in his eyes saying that he was not feeling well and that he needed immediate help. And thankfully, I was able to speak with him and talk with him. And they had an actual mental health advocate at that convention. And I was able to get him linked up with the advocate. And we were able to get him the immediate help that he needed. So that's just one example on just giving that presentation just one time. Maybe that'll help save a life. So it's a very, very important presentation, just advocacy and talking about this. The heart of QPR, again, is asking that very first question. And this goes into the heart of embracing the awkward. The hardest part of QPR is asking that very first question. It is one of the most awkward, strange, personal questions you'll ever ask to somebody. where someone in your personal life or your professional life, you have a massive concern over someone's safety, and you ask that first question, and you ask them if they're feeling safe, if they may be suicidal. It's a very awkward question to ask, but again, we've got to get to that point where we embrace it. And some of the key factors of QPR is obviously if we're in doubt, we're not going to wait. We're going to ask the question. I give the example. I always equate QPR with CPR. If I'm walking down the hallway, if I were to collapse, and if someone were to assess I need CPR to save my life, I would hope they would roll up their sleeves and perform CPR and not just assume or hope that I would be okay. QPR is the exact same way, is that we're not going to say, well, I have a concern, but I'm sure they're fine. I'm sure they're okay. I don't want to get too personal, so I'll just cross my fingers and hope they're okay. This needs to be viewed as a direct, immediate intervention that can be used to hopefully save someone's life. We're going to be persistent. This conversation needs to happen alone in a private setting. This is not a nurse's station type conversation. We're going to allow that person to talk freely, giving yourself plenty of time. What amazes me the most about QPR, as hard as it is to ask that first question, the person who does the most talking is the other person. Because again, it's so important to know people do talk about this. If somebody really is having suicidal thoughts or self-harm thoughts, people do talk about this. So it's a conversation. Again, that goes more into the persuasion part and the refer part, but which we'll go more into if you want to go through the actual class. But again, the hardest part is asking that first question. But there have been so many amazing examples on how lives have been saved by asking that very first question and saving someone's life. There's so many examples on how QPR has been that effective. So I believe in real life examples. And I'm going to share a couple of quick stories here because I really want to show examples of how QPR and how, again, behind the smile is saving lives. And this took place, this story here took place a couple of years ago. There was a drama teacher here in a local Casey high school. He was doing auditions for the spring play. The auditions were over for the week, and he was behind the curtain doing some notes. And he overheard some girls off to the side talking about the rehearsal. And he heard one girl say, and I quote, "Boy, if I don't get the part or the lead part in the spring play, I tell you what, I'm just going to go home and kill myself." And all the girls kind of laughed. I mean, they thought she was being sarcastic and being silly or funny or just being whatever. And the drama teacher said when he heard her say that, he thought to himself, he said, "You know what? I am 99.9% sure she's not suicidal. I'm sure she was just being sarcastic or just whatever." But he also thought to himself, "You know what? I am 0.01% unsure. So that warrants me having a conversation." And he had taken QPR before. He knew a lot about suicide prevention. So he implemented QPR and he asked her point blank if she was having self-harm thoughts or having suicidal thoughts. And tragically enough, she had an active plan to die by suicide if she did not get the spring play lead role. So his concerns were completely validated. And thankfully, unfortunately, he was able to help her get the immediate assistance and help that she needed. And she told him, the following year, she said, "If you had not done what you did, I might not be here." So again, that's just one example of many on how, again, looking behind the smile, implementing QPR, implementing suicide prevention was able to help save someone's life. I wanted to speak for a few moments here briefly on trauma. So one other course here we have at the KU Health System, it's called Trauma-Informed Care. Trauma-Informed Care was the main theme of my project for my DNP. And we've been teaching trauma-informed care courses now at the KU Health System for over almost 4.5 years now. We've trained over 12,000 total people, whether it be in the health system or outside the health system, nursing students, high school students, college students. It's a really great course, and again, it goes into some very key themes on doing whatever we can to prevent re-traumatizations for our patients when they're in the hospital setting. It also goes into a lot of detail on how we can best help healthcare providers, how we can best prevent cases of secondary PTSD, and how we can prevent being traumatized as healthcare providers. So if any of you want to have more information about that, feel free to reach out to me. We have those courses every other Wednesday from 2 to 3:30, all live, virtual via Teams. Again, my email address is tfunk@kumc.edu. Feel free to email me if you want more information about that. But I want to review a few brief things on trauma, because again, what we are learning right now, like with suicide, we are learning more and more and more about how many Americans are really suffering from many different mental health complications. And obviously, we talked about suicide prevention and also trauma. I think people for the longest time had this belief that, well, if you weren't a war veteran, then you can't have trauma. The last stat that we saw, 41% of Americans have some trauma history in some way, shape, or form. That's almost half of all Americans. And you can read this definition of trauma, which I have here on the slide. And the one sentence I want to focus on here for a moment is this: the individual's functioning and emotional, physical, social, and spiritual health can be affected. Again, we have that stigma that, well, it's trauma, it's PTSD, that's just a mental health concern. But what we're learning right now is that people who have been traumatized, especially when they've had trauma in their childhood years, this will affect you holistically, mind, body, and spirit, as you get older. There have been many, many acute care medical complications that have been associated or linked to high volumes of childhood trauma. So this is certainly holistic. So what is trauma-informed care? What it actually is, again, it's a framework that integrates 6 key principles into care to promote a safe place to heal. It promotes resilience in staff and patients. And there was a book that came out probably 4 or 5 years ago. The book was called Patients Come Second. And obviously, we know why we're in healthcare. We want to help people. That's why we're in this profession. The book goes into more detail about how, as healthcare providers, our mental health matters too. It truly does. And how this is a true culture change in healthcare. And I know all of us have had our stories related to COVID over the last almost 3 to 4 years now. We all have our stories. We all know what we have been through, and our stories and our moments with COVID and our situations with COVID. The number of healthcare providers who were diagnosed with trauma and secondary PTSD throughout the COVID pandemic, the numbers are just astronomical. So right now, more than ever before, we are doing everything we can to implement trauma-informed care, not only just for our patients, but also for our healthcare providers as well. I give the example that a friend of mine I went to nursing school with, she's an emergency room nurse at a very large hospital in downtown Chicago. And she told me recently that herself, along with every other ER nurse in the entire hospital, they've all been diagnosed with secondary PTSD. And they've actually had to hire 4 additional counselors just to provide weekly and daily therapy sessions and counseling groups for those ER nurses. So that should give you a little bit of an example, again, on just, again, how completely traumatized many healthcare professionals have been over the last 3 to 4 years, and how, again, our goal right now is to provide prevention and also immediate care for healthcare professionals who have been traumatized. So we talk a lot more about, again, secondary PTSD, otherwise known as vicarious trauma. It's so important to know that, again, for someone to have trauma, especially if you're a healthcare professional, the trauma itself, it doesn't have to happen to you. This really is about when when an individual hears about the firsthand trauma experiences of another. So you could be a nurse or whatever healthcare profession you have, just by reading about it, talking about it, assessing it, observing it, documenting it, that alone can lead to trauma and being diagnosed with secondary PTSD. You know, this picture here I put on here, I mean, I think if you worked in healthcare for a while, at some point you may have been here. This is not a good place to be. And for people who have secondary PTSD, here are the symptoms: chronic fatigue, poor concentration, disturbing thoughts, avoidance, emotional detachment. These are all the signs and symptoms of secondary PTSD. And this is what we're trying to prevent. I remember my very first nurse manager, this is right before I started working, and she said, Tanner, she said, I'm not 100% sure if you will be able to work here or not. I'm like, oh, okay. So why do you think that? She's like, well, she said, it's nothing personal. She just said, this is a very great place to work, but it's also a very hard place to work. And she said, as our lead admission nurse, she said, you are going to hear some stories from our patients and our families about emotional and physical and sexual abuse that are so severe, it will completely horrify you to your bones. Those were her exact words. And she said, will you be able to handle that? Will you be able to go through the roller coaster of emotions that comes with working here on a 12-hour shift, clock out, and then go home and live a normal, fully functional personal life? Will you be able to do that? And we'll give you resources and materials, but we'll see how you can do. And she said, my office door is always open if you ever need help. And I'm very thankful she had that proactive in service with me, because it took me a long time to really learn how to handle everything. And it was very good proactive advice. And it's just a reality that many of us face every day as healthcare professionals. Again, I know we've learned a lot and heard a lot about self-awareness, and also self-care over the past 4 to 5 years. Self-care, guys, I hope and hope and hope you hear and learn much more about it. We have an amazing self-care presentation in our mental health training program that's free, in our Helix department. Definitely take it. It's a great course on self-care. Um, One of the key areas I think of self-care, again, we know how important self-care is, and there's so many things we can do for self-care. However, a key part of self-care is self-awareness. Self-awareness has been a theme that I have been really involved with over the past 4 to 5 years. But self-awareness is about, again, looking at yourself in the mirror, looking behind the smile, and really identifying how you're really feeling. What's going well, what's not going well. Do you need help? Do you need assistance? And just being vulnerable and being real. That's hard for many of us to do. It's hard for me to do. But one of my favorite quotes about self-care is that patients deserve the best from us, not what is left from us. So it's one of my favorite quotes on self-care. So again, it's about having self-awareness and being able to be where we have to be with mind, body, and spirit to best take care of our patients and their families. And it's a huge part of Behind the Smile, where if we cannot even be real with ourselves, that's going to be a challenge going forward, about being real with yourself. I wanted to finish up on a happy story, and one of my main goals going into 2024, I want to make sure more and more and more people are fully aware of the many, many great, wonderful stories that happen in mental health every single day. Unfortunately, sometimes we only hear about the sad stories. I think for every sad story, there are at least 10 great, wonderful success stories that never get told. So I want to make sure we're sharing our mental health success stories as much as possible. And this one is one of my all-time favorites. This took place about 3.5 years ago. This was back in January of 2020. There was a police officer who got a dispatch call at 2 o'clock in the morning that there was a man who was literally hanging off the side of a bridge in downtown Kansas City. So the police officer drives to where the person's at. He gets out of his car, and the entire ordeal was on the police officer's body cam. And I was able to watch it. And it was about 30 minutes long. It was like out of the movie. It was one of the most dramatic things I've ever seen, where this police officer was doing everything he could to get this man to come back over the railing. This man was suicidal. He was going to jump. And again, it's the middle of the night in January. It's snow and ice and rain and sleet and snow, a very, very dramatic environment. And for the better part of a half an hour, that police officer said everything he could think of to get this man to come back over the railing. But the man just wouldn't do it. He said he was an alcoholic. He had fallen off the wagon. He had lost his wife, his kids, his job, his career, his home. He was homeless. He had hit bottom, and that he was going to jump. And as the police officer was talking to him, he was moving closer and closer and closer to him until probably he was about 5 feet away from him. And finally, the police officer could see that the man was wearing a Patrick Mahomes jersey. And I mean, the police officer could see what he was wearing. And then the police officer said, he just completely changes up the entire conversation. He says, "Sir, are you wearing a Patrick Mahomes jersey?" And the man was kind of startled with the change of conversation and the question. He says, "Yeah, I am." And the police officer says, "Wow." He said, "Yeah, I'm a big fan of the Chiefs too. I love Patrick Mahomes, and they're playing in the Super Bowl in a couple of weeks. How cool is that?" And then for the next 10 minutes, they were just two guys talking about the Kansas City Chiefs, the Super Bowl, and Travis Kelce and Patrick Mahomes, just two guys talking about the Chiefs. And finally, the police officer says, "You know what, sir, I have an amazing idea. How about if you come back over the railing? I'm going to put a big warm blanket on you. I'm going to give you a hug. We're going to get in my car and we're going to get out of here. And on Super Bowl Sunday, I'm going to invite you over to my house. I'm going to make barbecue. We're going to hang out. We're going to watch the Chiefs win the Super Bowl. And when we're done celebrating, we're going to sit down at my dining room table, and I'm going to help you put together a game plan to get your life back on track. I'm going to be your support person, and I'm going to help you put together." And these were his exact words. He said, I'm going to help you put together the best comeback story of all time." And the guy just started to cry, like happy tears. And he said, "Okay, I can do that." So he came back over the railing. They hugged. He put a blanket on him. They drove away. And I found out later on the police officer did all those things, and he had him over. And I found out months later that that man was doing very, very well. So I love that story because what the police officer was able to do, he did a couple things. One, he was able to provide a distraction, and he was able to help that man at the depths of his despair think about something that still meant a lot to him. Something even as trivial as sports and the Kansas City Chiefs, that still meant a lot to him. And he was able to help this man, have something to look forward to. And he gave that man just some hope that things can and will get better. So it's just one more reason why I love mental health. I love stories about mental health, and we have so much work to do right now as it relates to, helping people and saving people. And I think behind a smile, it's a critical part of what we're trying to do right now. It's about paying attention to people, listening to people, talking to people, asking important questions, and also embracing the awkward. When we have a concern, when we have a possible concern, we're asking questions, we're starting a conversation. And again, I think this is going to be one of our generation's biggest challenges, is learning how to help people the most with mental health complications. So anybody have any questions? I know we're right at the end of the time here. Any questions or thoughts or comments before we wrap up here. All right, everybody. Well, I appreciate you guys' time. Yeah, I'm going to go ahead and type in my email address here. If any of you have any other thoughts, questions, comments, feel free to reach out to me. Our health system has a plethora of mental health education programs that we share with everybody for free of charge. They're all worth CEUs. So let's see here. That is my email address there. So feel free to reach out to me if you have any other questions, thoughts, or comments. Thank you all and have yourselves a wonderful day.